Thanks. So I think in the agenda it says 2 talks, like 15 minutes and 45 minutes, one on the guidelines and one on buprenorphine. I've just sort of combined it all into one, and it's going to be 1 talk, and it's going to be less than an hour because it's already 20 past 1. Just before I start, I've done a number of talks over the last year or so here on opioids and buprenorphine. How many people here have been to one of the talks that I've given already? See, maybe about half or so. So I'll apologize in advance. There's a few slides, some slides that are repeats, and I'll go through those a little bit more briefly, but I think there's some key points that I want to make, and I think it'll still be beneficial for some of the people who haven't seen the talk. So like everyone else, no commercial relationships, just sort of some remuneration through Island Health and typical government and supports. So addiction in general, 3 points that I'd really like everyone to take home from this. And so we're shifting a little bit from chronic pain and addiction, which was mostly the morning with Lynette, to I'm going to be talking about just specifically addiction, opioid use disorder. And so for opioid use disorder and for addiction in general, number one, understanding that this is a chronic brain disease. You can use illness, you can use disorder, whatever you want to use, but this is a real issue and not something that's drug addiction is not a moral failing or lack of willpower. So that's number one I want everyone to really hopefully be clear on. Number two, that there's really good treatment for addiction, specifically for opioid addiction. And that really good treatment generally for most people is opioid agonist or opioid replacement treatment. And hopefully through this talk you'll come away with that idea. And the third is that all of society really benefits a lot from good treatment of addiction and opioid use disorder in particular. You know, with as many young people dying as we have now, and I mean people of all ages, obviously it affects entire communities, entire families. And so, you know, to think that this isn't my problem, or, you know, I live in Oak Bay and there's no addiction in certain areas or whatever, you know, just really isn't the case. And so we all need to take ownership of this issue and understand that we have a role in it. So just quickly, a couple slides. Addiction is a brain disease. So some of the seminal work for this was done by Nora Velko, who's an addiction psychiatrist, and she's the director of NIDA, the National Institute of Drug Abuse in the United States, sort of an addiction medicine rock star, if you will. And she'd done a whole bunch of neuroimaging studies showing the brain changes, neuroanatomical and functional brain changes in people with addiction. So basically doing studies on control brains and people with addiction for all different addictions, cocaine, methamphetamine, alcohol, heroin, showing specific and reproducible changes in people's brains, number one, as a result of drug use, but number two, leading to further drug use, right? So, you know, this often, you know, when I show this to family docs, it helps to have more compassion than we might otherwise have and see this really as an illness, to understand, you know, when people are making choices around their addiction, they're making these choices that make no sense because their brains are actually changed. And when you recover from addiction, probably some of those brain changes can revert, but probably they don't completely revert to baseline. And so that's why we think of addiction as a chronic disease. So the idea on the bottom here, starting to use drugs is a choice. Addiction is not a choice. No one chooses to have to be on the treadmill of addiction where you just constantly need to be getting more and more so that you're not sick. So addiction being a chronic disease, relapsing and remitting, so the goal with good treatment is actually remission, not cure. So we don't say people are completely cured from addiction, they're in remission. And so they're not using, and just like other diseases that people can be in remission, like asthma or COPD, we don't say that their COPD or asthma is cured, or diabetes. It's in remission, it's well controlled, and we can expect people, you know, to have life expectancies or qualities of life similar or just the same as anyone without, as long as their illness is in remission. And so this is just a paper sort of comparison of relapse rates between drug addiction and other chronic illnesses, diabetes, hypertension, asthma, showing that relapse rates are actually very favorably comparable to other chronic diseases. And like other chronic diseases, there's end organ damage, retinopathy, nephropathy, and diabetes. in addiction, the complicating factor is the end organ that's damaged is the brain, right? So that's our decision-making organ. And just like in cardiac disease, there's end organ damage in the heart. In addiction, the end organ damage is in the brain. So I'll just say a word or two on addiction versus physical dependence. And this is really critical to understand the difference between these two, because this is what allows us to distinguish between the two circles. Rashmi was just showing two circles of chronic pain and addiction, right? And now we know that they overlap. So there are some people with overlap, but everyone in both of these groups who are on opioids will have physiologic dependence to opioids, right? And so physiologic dependence is not the same as addiction. It is one small part of addiction, but it's not all of addiction. And so looking at the DSM-5, there's 11 criteria: impaired control, these ones, social impairment, these ones, risky use, these ones, pharmacologic, these tolerance and withdrawal. So all of these are part of addiction, but these are not all part of physiologic dependence, right? With all people with chronic pain on opioids have physiologic dependence, right? So when we're going to talk about the rapid access clinic a little bit later, but I'm working in the rapid access clinic and I'm starting to get a lot of patients being referred there who have chronic pain, who do not have opioid use disorder. They're having trouble getting off opioids because they or their physician want them to be off, and they get referred there. And that's actually not what that clinic is for, and that's not what we can actually manage and handle. And those people, although they're at increased risk of overdose just because they're on opioids, they are not at nearly the same increased risk of overdose as people who are using illicit opioids on the streets and buying heroin that's laced with fentanyl. So the rationale behind the rapid access clinic is one effort to try and reduce overdose deaths. And so, unfortunately, we can't see all chronic pain patients with opioids. So just when we're thinking of referring people, we need to, as much as possible, distinguish, is this a person who has chronic pain, or is this a person who has opioid use disorder, or is it a person who has both? And if it's a person, and that's not always easy to tease out, but in most cases, you can have a pretty good idea about that. And so if they have both, if they have just opioid use disorder, for sure, they should be coming to the rapid access clinic if you don't feel comfortable treating that yourself. If they have both, they absolutely should be also referred, because we know that we can't adequately treat chronic pain in the setting of untreated opioid addiction, right? But if they only have opioid use and chronic pain and they want to be off, or you want them to be off, or whatever, then that's something that is not going to be able to be seen at the rapid access clinic. I'm happy to try and help people walk through sort of opioid tapering, some of the things we learned here, but that's not something that we're going to be able to manage at the rapid access addiction clinic. So distinguishing between those two and really understanding the differences is important, and hopefully something that people will take away from today. So this is just a bit of a graph diagram. When people start using opioids, they use them because they get euphoria, and then they come back down when they stop using them. And pretty soon, they are going to a place where they have tolerance and physical dependence, and they are not actually getting euphoric anymore. They're just trying to keep themselves up into this normal level right here. And the withdrawal is what they're trying to get away from. And that's what we talked a little bit about with Ever this morning. So now getting on a little bit more to the guideline presentation. So this is a picture of Evan Wood and Terry Lake, and this woman's name is Leslie McBain, I think, and she is the father of Jordan, what's his last name? The mother of Jordan, who is one of the people who overdosed and died. That was in the paper a lot, he has quite a tragic story, and she spoke at I think the launch of the BCCSU, or one of the events, and basically the story was that he got started on opioids as a 22 or 23-year-old for a relatively minor workplace back injury, and pretty soon he started using them more. He liked what they felt like. He went to his family doctor and asked for help, and the family doctor was scared, not knowledgeable on opioid use disorder, cut him off. He started using opioids on the streets. Eventually they got him into a detox facility. He was in there for a little while, got detoxed very quickly off opioids, no follow-up treatment in terms of opioid agonist treatment, and then overdosed and died pretty soon after that when he relapsed because he was using fentanyl-laced heroin. So this is just some epidemiologic data going from the 90s until 2016, and we can see this sharp increase in number of deaths. And last year in 2016, there was 922 people who died from opioid overdoses, and this year we're on track for probably in the 1,500 person range. So it's getting worse, it's not getting better. Just another graph here, illicit drug overdoses, basically showing the same thing. This here is, the dashed line is illicit drugs excluding fentanyl, and you can see the number of people dying from other things other than fentanyl is going down, while as the number of people dying from fentanyl-related overdoses is going up dramatically. And it's just different areas of BC. As you can see, it's getting, this is 2015, 2016. Island Health is actually one of the hot spots in the whole province, but basically all over the province we're getting more and more deaths as a result of illicit drug overdose deaths. This is some really brand new data just from Island Health, number of overdose deaths in Island Health by month. And you can see here, through much of 2016, it was sort of in the teen area, low teens, pretty much between 10 and 15. And then in late 2016, it started really dramatically increasing. And in 2017, January, February, March, it's at the highest levels we've seen in Island Health ever. So this is getting worse, and that's one of the reasons that there's a lot of media coverage, and there's more resources coming on board to try and manage this issue, which we're going to go over a little bit more. So how did we get here? We've already kind of talked about this a lot. Too much opioid being consumed, too many opioid prescriptions, overestimating opioid benefit, underestimating harms, aggressive marketing by pharmaceutical companies throughout the 90s and early 2000s, lack of physician education around safe opioid prescribing. I mean, I'm sure for the vast majority of us in our medical training, we had little to no training specifically about harms and risks and safe prescribing of opioids. And illicit opioids have become much more potent quite recently, over the last 1, 2, 3 years, with the introduction of large amounts of fentanyl and carfentanil in the opioid supply. And the reason for this is just pretty much 100% economics. So a drug dealer buys $10,000 worth of heroin and they sell it for $20,000. They buy $10,000 worth of fentanyl and they sell it for $1 million. Right? Like, those are the numbers that we're talking about. So it's much more, you know, people say, why do drug dealers want to be killing their patients? That doesn't really make sense, does it? And I mean, they're not trying to kill people, probably, most of them, but they're obviously not concerned about their welfare primarily. They're concerned about, you know, 10,000 to 1 million instead of 10,000 to 20,000, right? So opioid addiction is old. I mean, there's been heroin dens and people have used heroin for decades, but the volume of deaths is new. And because we have so many people on a population level exposed to opioids, there's more people who are susceptible to ending up using those illicit opioids. So the other reason is a lack of access to evidence-based treatment for opioid use disorder. Little education about addiction in medical school, little knowledge around opioid addiction identification, and not enough knowledge about best treatment for opioid use disorder. And that's where the guidelines come in. And so the guidelines really help us understand what are the best evidence-based treatments for opioid addiction. The guideline for the management of opioid use disorder was released just a few months ago, February 2017, and it was basically an update and expansion of the Vancouver Coastal Health Guidelines, which came out about 1.5 years ago on treatment of opioid addiction. And so we'll go through some of the parts of this guideline now, but it's actually pretty straightforward. Just a slide about the level of evidence that they use. They use this particular way of classifying evidence. The point is that it's using sort of very rigorous standards to assess and evaluate evidence. So no member of the guideline committee reported direct financial or indirect conflicts. And so as we go through, you'll see there's a fairly strong evidence on buprenorphine. And I think it's really important that everyone understand that the makers of buprenorphine had no role in developing these guidelines. And the reason buprenorphine is being promoted as a really positive first-line option is basically because of its pharmacologic properties and its real benefits in terms of both efficacy and safety. So this is the summary page of the guidelines. So one of the challenging parts of the guidelines is it's quite long, and I think they're working on some abbreviated versions for family doctors, but you can get most of what you need to know just from the summary page. And I won't read through each of these summaries, each of these parts, but the bottom line is the top, this one says approaches to avoid. And the approach to avoid, number one, is withdrawal management alone. So people going into detox and rapidly withdrawing off opioids and then going out into the community has been shown, and I'll talk about this in a minute more, to be more harmful than nothing. Right? So if you do nothing for people, their overdose risk is less than if they go into an opioid, into a detox, inpatient detox facility, and then are discharged without significant follow-up and monitoring. So we don't do that anymore. Just as of the last year or two, I know at the detox here, Bill knows the details, but about a year ago, they completely stopped detoxing people off and are encouraging everyone with opioids to be starting on opioid agonist treatment. Of course, you can't force people to do anything, but we just inform people if they're much higher risk. So possible first-line treatments. The first-line treatments are basically buprenorphine and methadone. And they're advocating in this guideline that buprenorphine be sort of the 1A and methadone be the 1B, and that's largely because of the safety profile of buprenorphine being much, much safer than methadone, which makes a lot of sense, obviously. If withdrawal is going to happen, if someone insists on withdrawal, then it's recommended that it be done as an outpatient, on an outpatient basis over a longer period of time. So, summary, inpatient medical detox, more harmful, increased overdose risk, increased HIV seroconversion, slower outpatient opioid withdrawal, less dangerous, depends, not good evidence for its effectiveness generally, psychotherapeutic interventions, varied results, various intensities, various treatments, generally alone for people with severe opioid use disorder, generally not that effective. Residential treatment, there's no systematic reviews or meta-analyses. Relapse rates are generally very high. If someone is not on, this is for people in residential treatment not on opioid agonist treatment. No OAT, 2 times the risk of death on discharge. Generally disappointing given the costs and weights for most residential treatment. So this is just a slide, UN overdose preventing, opioid overdose preventing and reducing opioid mortality. So this is a UN document from the WHO saying basically exactly what the guideline says. So this isn't something that's been developed in Vancouver or developed in BC, or this is an international understanding and put out by the UN. The period immediately following release from prison and the period immediately following discharge from detox facility poses significantly elevated risk of overdose. And this, why do people relapse to opioids, and versus relapsing to other things maybe more than opioids, or less than opioids when they're detox sort of cold turkey? And it probably has something to do with just the way opioids grab people and the brain changes that are caused and the way opioid receptors function in our brain. But the data is pretty clear that that's not the right thing to do. So I won't go through the data on methadone maintenance very extensively, but it's probably one of the largest evidence bases that there is in medicine. Extensive Cochrane-level reviews of methadone maintenance showing that it's significantly more effective than non-pharmacologic approaches for both treatment, retention, and suppression of heroin use. From a whole bunch of papers, opioid agonist treatment reduces illicit opioid use, reduces IV drug use, needle sharing, multiple sex partners, HIV serum conversion, criminal behavior, mortality, shown directly to increase physical, mental health, employment, social functioning, quality of life. So there's a huge number of reasons why opioid agonist treatment works and works very well. So buprenorphine is relatively new compared to methadone. However, it's actually not that new in many countries around the world. It's been used in France and the United States for a number of decades. But Cochrane-level data, again, showing that at medium to high doses, buprenorphine is essentially similar to methadone in reducing illicit opioid use. So we now really know that for most people, or for many people, buprenorphine is going to be just as good in helping them stop using opioids, and it's going to be much safer. So the safety profile. So this is methadone deaths, methadone and buprenorphine deaths reported to US poison control centers. So between 2000 and 2008, as methadone is used more and more, methadone deaths have increased significantly. Buprenorphine, on the other hand, as it was used more and more, it's the red bars, and you can't actually even see them here, because buprenorphine deaths have not increased almost at all. And that's despite the rapidly increasing amount of buprenorphine prescribed. So these are dosage units of buprenorphine per 100,000 population in the US. And over that same time period, the amount of buprenorphine prescribed rapidly increased, and the deaths didn't increase at all. So that's the real reason that there's really a push towards prescribing buprenorphine for opioid use disorder, and a push to more liberally and easily prescribing it with less oversight because it's really safe. So this is France. Reduction in overdose mortality with expanded access to buprenorphine and naloxone. So in France, for a number of decades, all doctors essentially can prescribe buprenorphine. This line here, heroin overdoses in the 90s up quite high, dramatically decreasing. This is buprenorphine, patients given buprenorphine ramping up, and you can see the heroin doses dramatically decreasing, the heroin deaths. So that's what we're aiming for, basically. Methadone, this is in BC. Methadone is still prescribed at a much higher level than buprenorphine. This data is back ending in 2013. So that number has started to slowly increase for sure, but these need to be flipped. Right? So we need to have a lot of people on buprenorphine, a smaller number of people who are not responding to buprenorphine on methadone. So study out of England showing buprenorphine has a 6 times greater safety profile than methadone. In BC, 1 in 4 opioid prescription deaths, methadone is implicated. So let's talk about the magic of buprenorphine. Why is it such a great drug? And so I really hope I never present this slide when the pharma reps from buprenorphine are here, because they'll want me to speak for them. But I assure you that I am not paid by the pharma reps for buprenorphine, for Suboxone. But it is in a way magic because of 2 specific properties. Well, one specific property that results in the safety profile, really. And that is that buprenorphine, unlike methadone or morphine or all the other opioids, which are full agonists, is a partial agonist. So it only partially activates receptors, opioid receptors. But the magic about it is that it can, for the most part, for many people, most people probably, it can manage their opioid withdrawal. Right? So people will not be sick when they're on this, like they are, if they're off opioids. But because of this partial agonist effect, it doesn't have the harms and the risks nearly as much as other opioids. The other important point to understand about buprenorphine is that it has a very high affinity for opioid receptors. We'll talk about this a little bit because that has implications for how you start opioid buprenorphine. It's long-acting, so it lasts. Its half-life is roughly 37 hours. It's variable, so you only need to take it once a day, and sometimes you even only need to take it once every 2 days. And it's sublingually consumed. So safer, lower overdose risk, shorter time to stable dose. Another major advantage over methadone is that you could ramp people up on buprenorphine within a number of days, and they can get to a stable dose versus methadone, where it needs to be increased very slowly over a number of weeks, even months. There's fewer problems with QTC prolongation, fewer drug-drug interactions, fewer risks to diversion to the if diverted to the public, and you no longer need a methadone exemption to prescribe it. Up until about a year ago in BC, you needed a methadone exemption, license essentially, to prescribe buprenorphine, and as of July 1st, 2016, no one needs that anymore. And actually, as of the next month or so, you actually don't need any training. You can just prescribe it. I mean, obviously, it's good to get training for any drug that you prescribe, but like morphine, have you had specific training for morphine or prescribing oxycodone? If you haven't had specific training for those, which most of us haven't, then, well, we're starting to get it now with chronic pain prescribing CME, but we can prescribe buprenorphine as well, just as easily as we can prescribe any of those. So the only tricky thing really about buprenorphine is starting it at the very start, and we'll talk about that a little bit. So the take-home message, or one of the main take-home messages for the guidelines, is that buprenorphine is not the same as methadone. It works very well and similarly to methadone in the same way, but it's not the same because it's much safer. And so why is it much safer? And this is really the reason, because of the relative lack of respiratory depression with buprenorphine. So we have opioid effect on the y-axis and a log dose of opioid, so amount of opioid that someone's getting on the x-axis. So as you can see, for a normal opioid in the green line, as you increase the amount of opioid, their opioid effect goes up and up and up and up, and eventually you pass some ceiling effect, which is the threshold for respiratory depression. That's where this happens, which none of us want, obviously, right? So all these other opioids, as you keep increasing the dose, you keep increasing the respiratory depression. Buprenorphine, you keep increasing the dose, and after you get to a certain dose, it just doesn't do anything more, really, right? So people, it's very actually difficult to overdose on buprenorphine, and if you're not using alcohol or benzos or any other sedatives, I think it's next to impossible actually to overdose on buprenorphine if you're just using buprenorphine. I'm sure there's exceptions to everything, but in general, it's an extremely safe drug relative to other opioids for sure. So fentanyl crisis, easier access to Suboxone. The college deregulated it, so you don't need to have a methadone exemption. That's what this is talking about here. So the silver lining is buprenorphine is the first-line treatment, and it's available to family docs, like I've just been saying. Family docs are the most well-placed clinicians, actually, because that's where we encounter people all the time with opioid use disorder, whether we know it or not. If you're prescribing opioids, you probably have some people with an opioid use disorder in your practice. And particularly, this is a paper showing treating opioid addiction with buprenorphine in community-based primary care settings. So this compared patient experiences in a specialized addiction treatment setting versus getting buprenorphine with their primary care provider. And the outcomes were exactly the same in terms of patient retention and efficacy and how well it worked. But patients were much more happy and much more satisfied when they could get it in their medical home. So this is just another reason to think of us starting to do this, prescribe this for our patients. So a lot of people say that I can't prescribe buprenorphine because people need counseling and a whole bunch of other things to manage their addiction. And while it's true that holistically looking at people's opioid addiction or addiction in general is definitely favorable and advisable, this Cochrane review actually shows that psychosocial combined with agonist maintenance treatments versus just agonist maintenance treatments alone showed that there was no added benefit to psychosocial interventions. The medication itself is the most important thing. And I don't think this is to say, and this is controversial, right? And if you're presenting this to a room full of counselors, and you're not going to get some very good positive results. But the Cochrane, I mean, for anyone who's read Cochrane reviews, most of the time they say, well, we can't say anything. We've reviewed all this and we can't say anything. We need more research, right? And I think the bottom line is definitely different psychosocial interventions in certain people will be helpful for sure. But overall, for opioid addiction, for most people, if they've had any significant length of opioid addiction and it's moderate or severe, the most important thing is just giving them medication, just giving them medicine, right? And once you give them medicine, then they can do all of the other things. Then that opens up their ability to do all the other care that they need. So from the guidelines, again, withdrawal options, you can do buprenorphine taper, methadone taper, short-acting opioids, clonidine tapers. These are done to some extent in detoxes, but less and less. If you are going to do these, they should be done more as outpatients, doing longer, slower tapers, like slow being over many months. They should definitely be accompanied by intensive psychosocial follow-up. Ensure take-home naloxone, warn strongly of risks of overdose and death. So buprenorphine first line. If contraindications to buprenorphine, then methadone is second line. or 1A. And so in the guidelines, they have this figure, and this is sort of, looking at opioid use disorder in sort of a stepped care approach, I think is what makes sense. And for people with mild opioid use disorders or who have very short periods of time using opioids, then looking at withdrawal management with very robust psychosocial supports is potentially more of a realistic option. Agonist therapies with buprenorphine or methadone are really the mainstay of treatment of opioid use disorder. And then there's talk about a number of other specialist-led alternative approaches, including slow-release oral morphine, which is another option that's discussed in the guideline. But that's generally reserved for people with methadone exemptions and for people with experience treating opioid use disorder. And then, of course, harm reduction across all of this. So take-home naloxone kits, and if people are using intravenously, using clean needles, and using in supervised injection facilities, et cetera, et cetera. So summary, family doctors are a big part of the solution. Buprenorphine first line. Any physician can prescribe buprenorphine. The CPS-BC, the college guidelines, are still in effect until June 5th of 2017 now. In those guidelines, it strongly recommends you do a 3-hour online CME course like this one here. But after June 5th, the BC CSU guidelines will be the official guidelines for the province. Those guidelines do not require any training to prescribe buprenorphine. Of course, training is always good, and they encourage training. And in fact, this is a pharma online training. So the BC CSU is in the process right now of developing online methadone and online buprenorphine training modules that are going to be free and have no pharma bias. And so you can do these online modules either for methadone or for buprenorphine or for both and get training that you want for free with no pharma bias. And so anyone who's going to be prescribing buprenorphine, I would recommend that you do that. But I wouldn't recommend not doing that, getting in the way of you prescribing. So we just have a few minutes left here, and so what I'd like to talk just a little bit more about is the details of buprenorphine. And so these are a few slides that were repeated from the event in March where we had an evening on buprenorphine prescribing for family doctors. But we'll just do a little bit of pharmacology on buprenorphine because, as I mentioned, the one thing that's kind of tricky about buprenorphine is starting it at the very start. And so I'll explain to you why that is and how you can avoid the pitfall. And the pitfall is putting people into what's called precipitated withdrawal. So what can happen is you can actually cause people to go into very severe withdrawal if you give them buprenorphine when it's not the right time for them to get buprenorphine. And so if we look at a normal opioid, the little yellow figure is a normal opioid. The purple is an opioid receptor. The opioid binds to the opioid receptor, and a whole bunch of dopamine is released. And we can think of that in terms of turning the volume on the opioid receptor up to high, to 10. It's been turned all the way around to 10, right? So when a normal opioid comes in, it stimulates the receptor, turns the volume up to 10, and then you get pain relief if you have pain, and you get intoxication, euphoria if you don't have pain, or if you take a very high dose of it. And if you're in withdrawal, you get withdrawal resolution, right? So that's a normal opioid. Buprenorphine is a partial agonist. So when it comes and binds, it doesn't fully activate the receptor in the same way, and it turns the volume from 0 up to 6, not up to 10. It's a way of thinking of it. And so that's what happens when you have buprenorphine, which is fine. And the magic that we were talking about before is that 6 is enough for most people to manage withdrawal symptoms, which is great. It acts by binding to opioid receptors in the brain. So the two crucial properties are that it's a partial agonist, like we just said, but also the other really important thing to understand and remember is that it has a much higher binding affinity than most other opioids. So if there's other opioids in your system, it will actually knock off those other opioids. So you must start people on buprenorphine. You must start people on that when they are in moderate withdrawal. They don't have to be in horrible withdrawal, but they need to be in a bit of withdrawal, moderate withdrawal. And so if they're in moderate withdrawal here, They're used to having opioid in their system. They have no opioid, they have no dopamine, their volume is 0. Then you give them buprenorphine, their volume gets turned up from 0 to 6. They feel great. They feel much better. They're not in withdrawal anymore. They feel fine, which is what you want. If you have people who have opioid on board, so they've taken heroin, they've taken morphine, they've taken whatever opioid, methadone for sure, and their volume is at 10, and then you give them Suboxone, buprenorphine, you turn their volume from 10 down to 6 because the buprenorphine knocks off the other opioid because it binds so tightly. And because it's a partial agonist, it turns the volume down from 10 to 6. But it turns it down very fast, like within minutes, within 10, 15, 20 minutes, half an hour. And what people experience is incredible withdrawal all of a sudden, excruciating withdrawal. And people will describe it as the worst withdrawal they've ever experienced in their life. So you don't want to do that. That's not good. The good thing, though, is that it's not life-threatening. People don't die from it. Just like opioid withdrawal we were talking about, Lynette was talking about opioid withdrawal, you know, and we've all talked about it. It's not life-threatening. You don't seize and die like benzos, but it's very unpleasant. And one of the probably biggest harms, actually, to doing that, aside from obviously just, you know, greatly distressing your patients, is that it often turns people off buprenorphine forever, right? If they've never used it especially, and this is their first experience with it, they never want to try it again. And that just reduces one very good therapeutic option for them, right? So you really want to avoid doing that. And there's generally not that much you can do. Treatment is supportive. You can try giving more buprenorphine. Some people try using a stronger opioid that's also relatively tightly binding, but it generally you have to wait it out. So buprenorphine prescribing, very safe and forgiving. And once you've started someone, it's very easy to titrate people up. And you can do it quickly, you can do it slowly. There's evidence to suggest that doing it a bit more quickly helps with retention, but it's just relatively easy. Another kind of nice thing about it is there's a maximum dose. In Canada, it's 24. In the United States, it's 32 milligrams. So, you know, once you're at that dose, either it's working for them or it's not, right? And sometimes splitting it up or doing a few things like that makes a bit of a difference. But it's relatively easy to know, actually, whether it's working or not, because it's not like you're just going to, well, should I increase them more? Should I not? You're at 24. You're at 24, right? Or if you want to go to 32, that's the maximum dose, right? And you're not going to get much more after that. So generally, we start with daily witness ingestion at pharmacy until stable. Unlike methadone, where people need to be witnessed at the pharmacy for 12 weeks with drug-free urines, with Suboxone or buprenorphine, there's a lot more flexibility in terms of giving people take-home doses. Generally, I don't give people take-home doses if they're actively using still, or if they're unsafe, unhoused. They need to be able to store. Carries doses from the pharmacy. They need to be able to store the medication safely. I prefer having them have it in a locked container, just like any opioids. That's what I suggest. But the criteria for being able to have take-home doses is much lower. And the reason for that is because it's much less risky if it's diverted, right? If someone else gets the buprenorphine, it's much less likely to cause a fatal overdose than methadone. So, and a reason a lot of people drop out of opioid agonist treatment is because they have to go to the pharmacy every day, which is necessary for methadone to stabilize people, but not as necessary for buprenorphine. So just a couple more slides. Recent progress, both provincially and here in Island Health. So changes to the regulatory environment. We've talked about this as well already. No longer need to have a methadone exemption. Changes in access to funding for treatment. So Plan G now covers both buprenorphine and methadone, but people can get it covered much more easily now, which is removing a huge barrier. I remember even just 2 years ago when I moved here to Victoria, having to sort of fight and make calls to get special exceptions for people to get on buprenorphine really decreased the chances that people were going to go on that, start on that, and now it's just so much easier. The launch of the BCCSU, the BC Center for on Substance Use, I think is significant progress in terms of having sort of an organization that's specifically working to develop evidence and disseminate evidence-based treatments for opioid agonist treatment. They have a mandate for physician education and support. They've just put out this guideline for opioid use disorder. They're working on a guideline for alcohol use disorder, and I'm sure there'll be more guidelines and support following. We have overdose sites that have opened in Victoria, 3 of them. There's more clinical support for addiction treatment. There's a race line, rapid access to consultative expertise, a race line in Vancouver that you can call for support related to any addiction issue, but particularly opioid treatment. So rapid referral options. So here in Victoria, about a couple months now, we opened up a rapid access addiction clinic. And so rapid access addiction clinics have been opening up in various places. It's modeled after the Meta-Phi project, which is a project in Ontario that Mel Kahan, an addiction doctor out in Ontario, has started a network of rapid access clinics where in various different communities there's these clinics where people can be rapidly assessed for addiction issues and started on evidence-based treatments. So this clinic just opened up February 17th. Originally it was 2 days a week. As of last week, it's now open 4 days a week, 4 half days, Monday, Wednesday, Thursday, Friday mornings. And this is a short-term clinic. This is a clinic basically designed to get people started on opioid agonist treatment. And it doesn't have capacity to continue following people. So for most people on opioid agonist treatment, they're going to need to be on it long-term. The evidence is best for people who are on it long-term, and long-term means minimum 6 months to a year. For many people, much longer than that. And so that's where there's a huge need for capacity to take people who have been already started. So the difficult part is starting. The rapid access clinic is doing a lot of the heavy lifting in terms of getting people assessed and getting people started on opioid agonist treatment. And what we're looking for in the rapid access addiction clinic is for family doctors to be able to take patients back who are on a stable dose of buprenorphine. They have often really stabilized their lives and be able to continue prescribing long-term to them if as needed. For people who are not able to be transferred back to their family doctor, if they have a family doctor, they will be referred to the Pandora Clinic or Kool-Aid or the Outreach Services Clinic, which all do long-term prescribing of opioid agonist treatment. I encourage everyone here who has any opioid addiction patients, if they aren't comfortable starting buprenorphine themselves, definitely refer them to the Rapid Access Clinic, but expect that there will be a request to take them back. If for whatever reason people are not able or willing to take them back, they will still be cared for and they will still have access to long-term treatment. But ultimately, like I've mentioned a number of times, the best place for them to get that long-term care is going to be through their family doctor. And so family doctors are not going to be alone in trying to do this. And so there's a number of resources that have come in. One of the resources is this new position that Island Health has just created, and actually all health authorities across the province have relatively newly created physician leads for primary care addiction work. And so so I was fortunate enough to have that position just starting as of now, basically. And I'm going to be, it's not a lot of time, it's a half a day a week that I'm going to have basically to be dedicating to supporting family doctors in managing opioid addiction, right? And the RAC clinic is sort of one of the first things that's coming online to be able to support family doctors so that we can work together as a community to try and get those tragic numbers of overdoses down. And another thing that's coming that will be starting in June is an in-hospital addiction medicine consult service. So we've been working on that for about a year to put that together. Many other hospitals already have that. In most of the hospitals in BC, or not in BC, in a number of hospitals in BC, probably 4 or 5 other hospitals, including St. Paul's and the VGH and Surrey and and Royal Columbian have addiction medicine services, and I think it'll be really great to have an addiction medicine consult service here in Victoria. So there's help coming. It's not like this problem is being dumped on family doctors by any means, but family doctors are going to need to be a part of the solution. practical tips, I think this is the last slide here. Practical tips for continuing patients on buprenorphine. Get collateral from the initiating doctor. If you didn't initiate, using Pharmanet is critical. Improved retention if people are at least at 12 to 16 milligrams. The medication is taken sublingually. How long and who to do daily witness ingestion is a bit of an art to know that, but I'm happy to help people determine whether someone's ready for carries or not. But if you make a mistake and you give someone carries too early and they end up diverting it or something, you can be, confident that the risk is pretty low. But obviously you don't want that happening. Random pill counts and blister packing, like was mentioned, also are ways to help. And urine drug screens, of course, are a part of this treatment. And so there's billing codes for all of this, for urine drug screens and for maintenance treatment on buprenorphine, which I can go into the details of those for people. But the idea is not that people are going to have to be making a financial sacrifice as family doctors to do this work. It should be able to be done in a way that's reasonably compensated, which I think it is here in BC, which we're fortunate because it's not the case in all provinces. And the race line. So just primary care addiction care is where the majority of chronic disease is managed. Intensive specialized addiction care, internal medicine, psychiatry, pain as well, interventional pain, hospital care, detox, et cetera, et cetera. So this is just a little bit of summary. Buprenorphine first line, you don't need a methadone exemption. There's actually a free in-person training program that's being put on by the pharmaceutical company on May 27th that's going to spend about 4 or 5 hours going through all of their modules on their online thing that people are welcome to do if they want. The online buprenorphine course, like I mentioned, is from the BCCSU, is going to be starting very soon. But you won't require to take it. Any family doctors that prescribe opioids should be able to prescribe buprenorphine, and there's lots of local resources to help. And apparently you can go for 2 weeks to St. Paul's Hospital, and they'll pay you sessional payments to go there if you're really interested in getting some more good training. All the health authorities contributed to writing the guidelines, and that is it, I think. Yeah, acknowledgements, people who helped with the guidelines. So thank you very much. Sorry for rushing a little bit at the end there, but I really appreciate everyone's patience and time, and for people who was a bit of a repeat, I hope it wasn't too onerous to get through. But I don't know if we have time for questions now or we need to press ahead. What do you think? Do we have time for a question or two?
Yeah, maybe 1 or 2 questions.
Dr. Svorkdahl?
Quick question. You may have covered it already, but does the dose of morphine oral equivalent, so for example, if they're on 50 milligrams morphine oral equivalent, and then you decide to start them onto Suboxone, is there any kind of starting point with that?
No.
So then what would your recommendation be to start that dose of Suboxone at?
So I didn't go over the details of dosing of Suboxone starting people, but pretty much everyone starts on around 4 milligrams. And so the tablet is only in 8 and 2 milligram tablets. So most people start on 4. If you're concerned about precipitated withdrawal or the person hasn't been using any opioids for a while, some people start on 2, and then increasing up to 8 and 12 pretty quickly within the first day is generally how people do it. But Lynette probably has some very good insight into that as well.
So for the exact example that you gave, for 50 milligrams of morphine, you usually wouldn't use Suboxone, you'd use a Butrans patch if it's a pain patient, because the Butrans patch comes in 5, 10, and 20 microgram per hour. The 20 microgram per hour patch is equivalent to 80 milligrams of morphine. So if you gave somebody a couple milligrams of Suboxone, it would be way more than they needed. However, if it's an opiate use disorder, they're not using 50 milligrams of morphine. They're going to be using much, much more than that. And so what you need to do is, stop it. Ramm didn't have time in this presentation to talk about looking for their withdrawal symptoms. There are scoring tools they can use in the office, the COWS score, or at home scoring schools, the SOWS score, and you want to make sure they're on that before you initiate. So, but there is because there's not complete cross tolerance, just like with methadone, you can't say exactly if they're using so much, they're going to need so much. The other thing I just want to add, because Ramm was showing so well how it's a partial agonist, buprenorphine, and that it has high affinity for the receptor, and that's why it can kick you into withdrawal by knocking everything off, the other opiates off the receptor. But the other thing to know is that it's Suboxone, buprenorphine, is not a partial agonist when it comes to pain control. It's actually dose equivalent or a bit better than morphine. So it acts as a full agonist for pain. We're used to, yeah. And the other thing that can add to that precipitated withdrawal is that it's a kappa receptor antagonist. So if you push the dose too fast, you'll actually get activation through periaqueductal gray and stimulate D3 receptors, and you'll get tons of ekesthesia. So they'll get so, crazy in movement if you precipitate their withdrawal too much. So that's why there are schedules that you can put like a Butrans patch on the day you stop an opioid and let it transition over through the next day, and then start your Suboxone the next day and take the patch off, and you get almost no precipitated withdrawal. So I just start them on 1 milligram the next day after they've had a patch overnight, and then 2 milligrams a couple hours later, and do it really gently. Inpatient-wise, you have that luxury. Unfortunately, patches aren't covered.
That's true.
Yes.
And definitely using buprenorphine in a chronic pain setting is definitely different than using it in an addiction setting. So Lynette has much more experience than I do using it in a pain setting. In an addiction setting, like she said, we never see people using really low doses of opioids, or we don't use Butrans patches in addiction settings. So you can use it for induction for sure, but not that many people use it for induction. Yeah, I mean, if you have access to that, you can, but it's quite uncommon to do that. Not as an outpatient, and not, yeah.